on to the next talk, I invite Dr. Fairooz PM to deliver her talk on congenital ptosis, evaluation and management.
Thank you so much for this kind invitation. I'm extremely grateful to Dr. Santosh Unava, Dr. Namrata, and the organizing team for giving me this platform, because Aishala is something that I really like. So it evolved as the mother of PG education in AIOS many, many years back. So the hall used to be like filled with PG students. So well, we do have some. Who are the postgraduate students here? Okay, sir. So well, yeah, so this topic, I believe it's important as far as a postgraduate is concerned, because this is definitely going to be one of your case, if at all an oculoplasty case is going to be kept for you in viva, in practicals, and also in theory. And I'm happy to deliver this. Now, we have general ophthalmologists here. It's again a very important topic, because you need to know when to refer and how to deal with it. And as a specialist oculoplastic surgeon, there are many gray areas: when to refer, when to do the surgery, and what are the indications of surgery. And the topic given to me is very specific, because ptosis is a vast topic. It's congenital ptosis, evaluation and management. But I'm going to touch upon a few basic things, because we have so many postgraduate students here. Well, I'm Fairooz, I'm from Bangalore. These are my previous affiliations and my current affiliation and financial disclosure. Before we go on to the topic as such, well, knowing the eyelid anatomy is very important. Your eyelid anatomy is your essay for your postgraduates. Now, why is it important? Because there are few muscles. There are 3 muscles which is involved in the lifting of the eyelid. Most importantly, it is the levator palpebrae superioris, which accounts to 15 millimeters of eyelid lift. Then you have the Muller's muscle, which lifts around 2 millimeters, all right? And then, of course, frontalis muscle is also involved in the lifting of the eyelid, which, at various points helps in your diagnosis and helps in your management. Eyelid embryology, of course, very important. Anyone, eyelid embryology, how is it important in ptosis? Well, it's a huge hall. I thought of keeping it interactive. I think it's going to be difficult. So eyelid embryology is important because it is, eyelid embryologically arises from the neural crest infiltrated mesenchyme and surface ectoderm. So the lacrimal system is also from the surface ectoderm, and we have the puncta, canaliculi, everything arising from the same. And well, we have the extraocular muscle, and then we have the levator palpebrae superioris, which actually, weakness of which leads to ptosis. So there can be a relation between the superior rectus and the levator palpebrae superioris, where it has a very common embryological origin. We'll come to that in the clinical aspect of it. Now, when we talk about specifically about congenital blepharoptosis, first is the classification. It's classified as simple, just a ptosis, and then you have a complex blepharoptosis, which could be associated with double elevator palsy or a monocular elevation deficit, Marcus-Gun-jaw winking phenomenon, Horner's syndrome, or aberrant third nerve. Now, what you see here is a very cute chubby baby with a unilateral simple ptosis. Here you have a bilateral simple ptosis. Now, what is very classical in a ptosis is when the child has down gaze, there is an increase in the palpebral fissure. In fact, the eyelid is much more wider. And why is it that? Because a congenitally abnormal levator palpebrae superioris neither contracts nor relaxes. So it's like fibrotic. So you have a ptosis which is not moving, it's not flexible, and then we are going down, it's again not flexible, which is holding the eyelid up, and this is very classical, okay, in order to differentiate it from an acquired ptosis, which could be an aponeurotic ptosis, all right? Now, looking at the mouth, can you diagnose a ptosis? So this is a child, well, nice, and the other one is a pursed lips, all right? So now you see here that the ptosis is variable, all right? So the left eye has a ptosis with the normal lips and the jaw muscle, but as you can see here, when the child clenches or eats or chews, well, the ptosis gets corrected, and that is a complex ptosis. So if you have a small child, feed the child something in the clinic in order to identify this, because this is a common association. If it's a bigger child, give a lollipop and ask the child to move a jaw. Now, we can have very complex blepharoptosis. So this is a very interesting case which walked into my clinic where the child had bilateral ptosis. Now, on opening or the movement of the jaw, you can see there is a Marcus gun jaw winking phenomenon in the right eye, and there is actually increase of ptosis in the left eye, and there is a elevation deficit. So the superior rectus is involved. So there is a lot of aberration going on here. There is weakness of levator palpebrae superioris going on here, and the superior rectus muscle is involved. So you can have complex to very complex blepharoptosis, and a clinical evaluation is very, very important because your management definitely depends and your outcome depends on your clinical evaluation. Yet another complex blepharoptosis. So this is called the blepharophimosis syndrome. So blepharophimosis syndrome, I would have told this thousands of times in most of my ptosis presentations. This was my essay for my postgraduate exam back in 2009. I had no idea how to write an essay on blepharophimosis syndrome. I wrote the exam, then I went back to the library and I read about blepharophimosis syndrome. So there is lots to read about blepharophimosis syndrome, and make sure that, so there is yet other names. It's called the Kuhn-Romanowski syndrome, and it's also called the congenital tetrad syndrome. And why is it called congenital tetrad syndrome? Because there are 4 clinical features here. Of course, there is blepharophimosis. The eyelid is small. The horizontal and the vertical palpebral fissure is small. There is ptosis, epicanthus inversus, and telecanthus. Now, depending upon the hereditary, it can be hereditary. So it has an autosomal dominant pattern. Depending upon that, it can be type 1 and type 2. Female child with blepharophimosis syndrome can have an ovarian dysfunction, and depending upon the 4 clinical features, it is again categorized and classified into type 1, type 2, type 3, and type 4. I want you to go back and read about this in detail. Regarding the clinical evaluation, yes, it's a lot of things that we do, especially in congenital ptosis. Acquired aponeurotic ptosis, which is senile, is much more straightforward than congenital ptosis because it can be again associated with various syndromes. So family history is important in congenital. Here you have a mother who has a ptosis, who has undergone a surgery. You can see the scar marks, and the baby is also having a ptosis over here. The age of onset, the mode of onset, laterality, whether there is diurnal variation. Yes, you can have congenital myasthenia gravis, progression, history of trauma, forceps delivery, prior surgeries, whether anything has to be done, medications, and you have to also look for periocular and systemic symptoms in these children. Now, important and directly related to ptosis evaluation is in a child when they present with a congenital ptosis is corneal reflex. That means the visual axis, whether it's exposed or covered, the facial symmetry, head posture, eyelid crease, frontalis overaction, and ptosis measurement. So this child has a left eye where the eyelid is completely covering the visual axis, corneal reflex. So there is a high risk of amblyopia in this child. Now, ptosis measurement parameters, we have a list of it. Even at this point of time in my practice, I write 1, 2, 3, 4, 5, 6, 7. And these are the lists that I'm going to discuss here. So when you clinically examine a patient with ptosis, first you look at the palpebral fissure height. So this figure image has a ptosis in the left eye. So the palpebral fissure height is very simple. It is from the center of the upper eyelid to the center of the lower eyelid crossing the pupillary axis. Simple as that, and that is palpebral fissure height. You always look for the down gaze palpebral fissure height. As I told you, you will be able to differentiate this between a congenital ptosis or an aponeurotic acquired ptosis. Can acquired aponeurotic ptosis happen in a child? Yes, in those children who has, yeah? Birth trauma, acquired, yes. Allergy, Bicasi, yeah? So children with severe allergy, they keep rubbing their eyes. They can have GPCs in the upper tarsal, so it can be mechanical, and it can also be aponeurotic, so they can present. All right, so in those acquired aponeurotic ptosis, when the child looks down, the palpebral fissure will be less compared to the normal eye, where here it will be more when compared to the normal eye. Marginal crease distance. Most importantly, we give importance to the MRD1, which is from the center of the upper eyelid to the pupillary reflex, the corneal reflex. MRD2 is also there, and that's important only when you have a inferior scleral show, to assess the outcome and explain to the patient. But basically, MRD1 is more important. Lid crease and the skin, and that is very important. So in a congenital ptosis, if the lid crease is present, it's a good news. Okay? Levator palpebrae superioris inserts to the orbicularis and then reaches the skin, and then you form a lid crease. So that indicates that there is some function to the levator palpebrae superioris. So I know, okay, even if the child is 6-month-old or 9-month-old, the child comes with a small crease, I know, oh, that's a good news. I tell the parents, don't worry, the surgery is going to be fine. It's not a severe ptosis. But the absence of lid crease indicates that it's a severe ptosis, that the levator palpebrae superioris function is going to be very, very poor. And this is important clue in a clinical evaluation, because for a small baby, it's really important to analyze the LPS action, clinically holding the frontalis, the child is not going to cooperate. Lid crease distance. So the lid crease distance will be again from the central upper eyelid to the crease, which is visible, the more prominent crease. LPS action, this is how we evaluate. We ask the patient to look down, and then we block the frontalis muscle action, and then we ask the child or the patient to look up, extreme up gaze. So the excursion of the eyelid is taken, and that's how we measure the levator palpebrae superioris action. Bell's phenomenon is important in order to decide whether, the surgery, the extent of lid height that you're going to take over, and what is the risk of corneal exposure post-surgery, and the lag off. Marcus-Ganjow winking phenomenon, we have already spoken about it. Ocular motility is very, very important. In various scenarios in ptosis, as I told you, there can be deficiency of supraduction in these patients because of the superior rectus involvement, and I'll come to a few cases which is again more interesting. Frontalis action, frontalis overaction. So if it's a severe ptosis, and if I am planning for a surgery for a frontalis sling, I need a good action frontalis. If my frontalis is not good, the child is not overacting frontalis, even if I do a sling surgery, my lid is not going to be elevated up. So that's surgically very, very important for deciding, what I'm gonna do. Head and chin position. Now, pupil assessment, yes, it's important. So you see a ptosis here in the right eye, right? Is the pupil evident in the screen? Yeah? Diagnosis? Yes, Dr. Rashmin. Pupil is seen. You can see the pupil of the right and the left eye. You can give me the diagnosis here. PGs. Yes. You give me all answers. Right eye. Acquired ptosis. Okay. Mother says that she has been having this as a child. Rolika Bansal, no. You have won all the quizzes and you know it. You're done. You're no more a resident. Anyone? Okay, let me show you the pupil, okay? So this is the right eye, ptotic eye. Okay, this is the left eye. Any difference? Pupil is same. Anisocoria is there. Which is small and which is big? Right eye is small and left eye is big. So, what is small pupil called as? Did you have the neuro-ophthalmology class from Dr. Rashman already? No, that is the problem. All right. So, tell me, a small pupil is called what? Terminology. What's a term? Meiosis, right? Yeah. Ptosis. Answer. Horner syndrome. Okay, yeah. So pupil assessment is also very important. Well, you can have congenital third nerve palsy. In that also, it's very, very important. So it's very important. Now, this particular thing I just wanted to show you, well, you see there is a ptosis of right eye and there is a retraction of the left eye. Yeah. So is it ptosis of the right eye or retraction of the left eye? What's the diagnosis here? I can play it again. Yeah? What? Ptosis of the right eye. Yeah. So you all know about the Herring's law, right? Yeah. So this is a very classical Herring's law where parents are also confused. When they come to you, they don't know which eyelid is abnormal, whether it's a ptotic eye which is abnormal or whether it's even in adults in oculoplastic surgeon, we sometimes are thinking, okay, is it a thyroid retraction in the other eye? Then we investigate and we find out, especially in milder ptosis, right? Yeah. So this is important. This is how after correction of the ptosis, the other eyelid has still come down. Well, not too symmetric, but still symmetric. So why is it important? Because first of all, you have to explain to the parent, this is why there is a Herring's rule. And as a surgeon, it's so very important for me because if there is a asymmetric bilateral ptosis, all right, asymmetric, one is very evident and the other one is very mild, I have to tell the parent, now the better eye is looking normal for you because of the Herring's reflex. Now, when I correct the good eye, the other eye is going to drop down and it's a bilateral ptosis. So it's very difficult to convince a parent when one is looking too severe and the other one is okay. They're like, no, it's just one eyelid. Then you have to explain to them. But then later they would come to you and tell, you did surgery in one eye and listen what happened. You created a ptosis in the other eye. So this Herring's law has to be clearly defined to the parents. Now, this is a very interesting case. Handsome gentleman. So he has bilateral ptosis, but he believed he had ptosis only in the left eye. I couldn't convince him, all right? I said, listen, we have to do bilateral ptosis surgery. And he said, and it's a congenital ptosis. He operated when he was in his late 20s. And then he said, no, let me just do the left eye. I don't think the right eye is that bad. Left eye is more bad than the right eye. So this is what happens. This is 6 weeks post-op. The other eye dropped more down. But I had explained to him. I had already told him, so I was saved. All right? Then we had to do the other eye as well. And this is 6 months post-op. So Herring's is very, very important. All right? You should know about it. Now, ptosis measurement and the severity, how you classify it, basically depending upon the degree of ptosis, and that's called the Beard's method, depending upon the pupillary reflex and whether the eyelid is at the upper border, whether it's in the middle of the pupillary reflex or in the lower border of the pupillary reflex. And that is how we say mild, moderate and severe, and also depending upon the LPS action. Always rule out pseudotosis. Assessment of best corrected visual acuity and assessment of ocular motility is important. Management of blepharoptosis is basically the risk of amblyopia in children, functional deformity, and a cosmetic concern. So this is bilateral complete closure of the corneal reflex, high risk of amblyopia, unilateral, plus or minus, whether you want to do it now, the parents can decide. Now this child, when he gets tired, it can really drop down. So this I would operate now, this I would operate now, this maybe I will wait when the parents comes back. Now, the various options we have in mild ptosis, molarectomy, Fastenella servat, in moderate, LPS reattachment resection, in severe, supramaximal LPS resection with null sling and tarsofrontal sling. So this is how we do a tarsofrontal sling, simple procedure. This is how we mark the eyebrow. That is a lid near the lash. So we take a traction sutures. I'm going to play it fast. Locally infiltrate. We open up 2 stab incision in the forehead and either side of the brow, medial and lateral. Pass the silicone sling from the forehead incision to the brow incision, then through the brow incision, then we come to the eyelid over here. I'm running out of time. Okay. And then you come out here, and then you take it, and then you tighten it. Yeah, and then you lift it and you tie it here. 1 second, I'm so sorry. Yeah. All right, so these are the bilateral complex blepharoptosis, inferior rectus aplasia, upper lacrimal puncta, canalicular agenesis, this is what the child had, blepharophimosis syndrome lifted, blepharophimosis syndrome, cosmetic surgery with medial canthoplasty, lateral canthoplasty, Marcus-Gunjow winking phenomenon. We do LPS excision and frontalis sling surgery, not going into the detail, supramaximal LPS resection of the left eye here, and Whitnall sling in very, very severe ptosis. So take-home message is, it's exam-oriented topic. You need to know everything about congenital blepharoptosis. Thank you so much. Eye is the window of the human body through which it feels its way and enjoys the beauty of the world, and eyelid is definitely the curtain, and it's important. Thank you so much.